Good afternoon. Today's class will be based on the surgeries for distal penile hypospadias. The contents of the presentation will be oriented towards a basic introduction to the topic, the various procedures which are available, the pre-op evaluation and patient preparation, the basic principles of a hypospadias surgery. Then we'll discuss in detail regarding the commonly used surgical options which are available to us, and also regarding the post-op care of a hypospadias repair. And finally, we'll end up with discussion regarding the major complications following surgery. As we know, hypospadias involves three major components. Not changing. Hello, am I audible, sir? No, net is slow.
Disconnect from.
Yeah. Hello. It is changing. Sir, am I audible? Oh, it is disconnected. Hello.
Say to your presentation means we are only seeing the first slide.
Yes, sir.
There is no audio also.
Sir, some network issue was there, sir. It got reconnected.
There is no audio also.
Yes, sir.
So you start off from beginning.
Sure, sir. Sure. So today's topic will be regarding surgeries for distal penile hypospadias. The contents of the presentation will be oriented towards a basic introduction to the topic, the various procedures which are available regarding the pre-op evaluation and patient preparation, and we'll discuss regarding the basic principles of hypospadias surgery, and we'll discuss in detail regarding the various commonly used surgical procedures, and also regarding post-op care of a hypospadias case, and eventually we will discuss regarding the major complications associated with the various procedures. Coming to hypospadias, basically it has got three major components. That is, one is an abnormal ventral opening of the urethral meatus, an abnormal ventral curvature of the penis called as CODI, an abnormal dorsal hood distribution of the foreskin with the ventral deficiency of the foreskin. That is called as a dorsal hooding. And you see the classification of the hypospadias. The distal penile hypospadias includes glandular hypospadias, coronal, subcoronal, and also anterior penile hypospadias, which mostly accounts for almost 60% of the 60 to 70% of the total number of cases when compared to proximal hypospadias. Today's class will be more oriented towards surgical options for distal penile hypospadias, and the proximal penile hypospadias surgery will be covered in the upcoming class. Already, the anatomy and embryology was covered in the previous class. So, distal penile hypospadias, if you consider, the need for treatment is mostly dependent on the cultural preference of the family, especially in cases of glandular and coronal hypospadias, where you don't see a proper functional defect, because in those cases mostly the child will be able to void with a good downward stream away from the body. So in those cases, the major concern for the family will be the cosmetic appearance, especially the deficiency of the ventral skin and also the abnormal urethral opening rather than a functional defect. So the goal of surgery in such cases will be essentially cosmetic. Hence, in such cases, the outcome needs to be as close to perfect as possible. The technique of surgery always depends on individual penile anatomy. The Various commonly used procedures for distal penile hypospadias includes a MAGPI procedure, that is meatal advancement with glansplasty incorporated, a gap procedure, that is glans approximation procedure, the Urethral procedure, and coming to commonly used tubular incised plate urethroplasty procedure popularized by Snodgrass, and also a tip procedure with an inlay graft. The other procedures includes Matthew's flip-flap technique and an onlay flap. Urethral advancement techniques are also available, and a pyramid procedure, especially for megameatus intact profuse type of distal hypospadias. We'll be coming into details of each in the upcoming slides. And we'll come to the principles of hypospadias repair. The basic principles of hypospadias repair includes an orthoplasty or a cody correction, followed by a urethroplasty and its reinforcement. The third principle will be glans and meatoplasty and glansplasty, followed by a skin approximation. Another basic dictum which we should follow in a hypospadias repair is judicious and precise use of electrosurgical unit for hemostasis. Then there must be careful use of local vasoconstrictive agent and tourniquet, and ischemia time shouldn't cross 50 to 60 minutes. And always for a precise procedure, there should be use of optical magnification ranging from 2.5 to 3.5x. Coming to the pre-op evaluation and preparation of a patient with distal penile hypospadias, routine evaluation of upper urinary tract is not recommended in a case of isolated hypospadias. And if you consider endocrine and genetic workup, it is indicated mostly in severe proximal hypospadias rather than distal hypospadias with cryptorchidism. So this has no role in distal penile hypospadias. Coming to the pre-op preparation part and hormonal therapy, hormone supplementation may be useful in children with microphallus and also with previously failed repairs in which the local tissues are deficient. The pre-op hormonal therapy includes usage of beta-HCG and testosterone. Beta-HCG, it has been found that it increases the vascularity and thickness of the proximal corpus, and the dosage for the beta-HCG is 250 to 500 international units per dose, which is given twice weekly for 5 weeks. And another preoperative hormone stimulation agent is testosterone, which is available as IM injection and also as topical depot application. So the effects which we can see following testosterone use is increasing the penile size along with improved skin availability and local vascularity. And in few studies, it has also been shown that these are found to decrease the severity of cody and also the severity of hypospadias. The dose for testosterone which we use is 1 to 2 mg per kg per dose as an IM dose. Once given as an OD dose, a stat dose which is given 3 weeks apart. Every 21 days you will give one dose, and total there will be three doses, and maximum dose which you can give at once is 25 milligram per day. These are the various literatures which are available on the pre-op hormonal stimulation, and it has been quoted that the effect of preoperative hormone stimulation on the postoperative outcomes remain unclear and requires further investigation in a major meta-analysis which is published in Journal of Urology in 2013. So, but in the recent studies, it has been shown that there is a decrease in the postoperative complication rate following preoperative hormone stimulation. Regarding the timing of surgery, the ideal time for doing a hypospadias repair in a child is between 6 to 12 months of age group, because this has been this has been advocated in view of psychological effects of the genital surgery in children. Before they realize that such a surgery is happening to them, it is better that you do the surgery in the infancy period itself. And also with improved technical aspects of hypospadias surgery with optical magnification and advent of pediatric anesthesia, it is possible to do such surgeries in an earlier age group itself, especially in 6 months to 12 months time. And another advantage is that the postoperative management of the interleaving catheter or the the urethral stent and also dressing is easier when compared to older children. Coming to the anesthesia part for hypospadias repair, preferably general anesthesia is preferred with regional analgesia which might include a caudal or a penile block. But it has been found that if you give a caudal anesthesia as an adjunct, some papers are showing that it can increase the complication rate of urethral fistula, because this has been accounted to the fact that if you give a caudal block, there can be venous congestion in the corpora, which in turn can increase the risk of hematoma in the suture line, and which in turn can lead on to urethral fistula in the postoperative period. Coming to the major steps of hypospadias repair, first one will be an orthoplasty or a CODI correction. The degree of CODI always influences the type of repair which you are planning to use. And CODI can be assessed partially in the preoperative period, but a complete or an accurate assessment of CODI is feasible only in the intraoperative period after deglowing the penis and after doing a artificial erection test called as a GTS test. So in GTS, what we do is, as you can see in that picture, using a 25 gauge butterfly needle, you are injecting 5 ml of saline into the corpora so that it will create an artificial erection of the penis. So in some textbooks, it has been advised that it is better that you go through the glands for injection of the saline rather than going through the lateral aspect of the corpora, because it might create a hematoma under the buccal fascia. So if you go through the glands, that can be prevented. So there are various steps for CODI correction. Mostly, majority of the CODI will get corrected once you deglow the penis. The skin level CODIs will get corrected once you deglow the penis till the base of the penis. So after that, you again assess the penis with erection test. And if residual CODI is there, and if it is less than 30%, the following procedures can be used to correct it. So the first procedure which is described was a dorsal midline plication. So as we know that the neurovascular bundle of the penile tissue runs at around 10 o'clock and 2 o'clock position, and it is away from the midline. So a dorsal bite is taken over the corpora at the part of the maximum curvature so that the CODI can be straightened. That is one procedure where which we can use to correct the CODI if it is less than 30 degree. And followed by another procedure is a Nesbitt plication. Nesbitt plication is that you open the tunica albuginea on the dorsolateral aspect, and just like doing a Hincke-Mikulicz procedure, you open it in a vertical fashion and close it in a horizontal fashion. So that is Nesbitt plication, which is done at the area of maximum curvature in the dorsolateral aspect. So before doing this, you should elevate the buccal fascia so that the neurovascular bundle goes along with the buccal fascia into the midline, so that you won't damage it. And the thing we need to remember is rest of the areas for suturing, we use always absorbable suture material. But in case of plication, it is always better that you use a non-absorbable material like 6-0 Prolene. Then Duckett modified the Nesbitt's plication with the procedure which is shown here. As you can see, the Duckett modification includes, it is similar to that of Nesbitt plication, but you are excising a part of the tunica albuginea. Two elliptical incisions are made, and that elliptical part of tissue is excised off, and then the outermost layers are brought together with an inlaying knot. So that is another way of doing a CODI correction. That is called as Duckett modification. The thing which you need to keep in mind while doing this dorsolateral plication is that we shouldn't injure the neurovascular bundle, which has to be brought medially. The neurovascular bundle has to be brought medially to prevent any injury. So if the CODI is more than 30 degree, these procedures will not help in correcting the CODI. Then you will have to go ahead with the urethral plate division in the ventral aspect. And in some cases, if the penile length is short, then we'll have to go ahead with a ventral patch graft also. So after dividing the urethral plate, that defect which is formed, you can cover it with a ventral deepithelialized patch graft, which is taken from the groin. Coming to urethroplasty, the basic principle behind urethroplasty is meticulous tissue transfer, and the tissue source which we can use is, one is an adjacent tissue, and then local tissue flaps can be used, or a free graft from either genital or extragenital tissue origin can be utilized. The local tissue flaps which are utilized must be thin, it should be non-hair bearing and easy to handle. Coming to the neourethral coverage, ideally multi-layer coverage of the urethroplasty suture line is preferred, and every time the suture line should not be placed over each other, so that in that case urethrocuteneous fistula chances will be more. So all the suture lines should be lying in different planes, and multi-layer coverage decreases the risk of or the rate of urethrocuteneous fistula, and also improves functional and cosmetic outcome as it gives a bulk to the penis. So this is how we do urethroplasty with a multi-layer approach. The local tissues can also be used, as you see in here. The splayed spongiosum can be used to cover the urethroplasty site, as seen on the right side of the screen. Coming to meatoplasty and glansplasty, this involves suturing of the meatus to the glands and also mobilizing the gland swings and approximation of the mobilized gland swings. But the most important thing is that the entire repair can fail if this gland swing mobilization is not done properly. And if you are suturing the gland swings in an inadequate manner with tension, it will give away, and also it will lead on to a blowout type of urethrocuteneous fistula, and risk of meatal stenosis will also be there. Whenever you are doing a meatoplasty, it like the main thing to keep in mind is that you need to spatulate the distal end of the urethra rather than going with a circular meatoplasty, because the chances of meatal stenosis will be more if you are ending it as a like circular meatoplasty. So always try to spatulate it so that stenosis risk will be less. And the final meatal caliber which you are aiming here should be 8 French for an infant, and at least it should be 10 French for children older than 3 years. And as I said, there should be generous spatulation of the neomeatus. Otherwise, there will be risk of meatal stenosis. Coming to intraop decision making, so the main thing which we need to keep in mind before going ahead with the procedure is that you shouldn't stamp any procedure on a particular child. If you are comfortable with a particular procedure, you shouldn't apply the same procedure for all the patients of hypospadias which presents you. So no procedure is actually universal for a hypospadias. So depending upon the individual and penile anatomy, you should modify the procedure. So surgeon should have the versatility, and surgeon should be flexible. So, and he should have the different, should be like well versed in different techniques, so that he can identify the penile anatomy in a better way, and he can employ whichever technique is best suited for a particular case. Now we will discuss regarding individual procedures. First, we will discuss regarding MAGPI, that is meatal advancement glansplasty incorporated. So MAGPI is a technique which is ideal for glandular and some of the coronal hypospadias without CODI. So this is an important concept, that CODI shouldn't be there, otherwise the procedure will fail. It is not feasible if CODI is there. And MAGPI is a simple but elegant procedure with an excellent functional and cosmetic outcome, and it has got less chance for a urethrocuteneous fistula. But the risk associated with the MAGPI procedure is that there can be chance for a meatal retraction. So this is how we do a MAGPI procedure. So if you can see the first figure, sorry, this is the abnormal meatus. Distal to the meatus, you can see the bridge of glands tissue, followed by a glands groove. So initially you take the gland stitch. After that, you will have to deglue the penis, and following which you put you make a vertical incision, deep incision, breaking the glands, that small bridge of tissue distal to the abnormal meatus, so that it will form a diamond shaped deformity. Then you will close the diamond shaped deformity in a horizontal manner, just like Heineke-Mikulicz procedure, so that there will be advancement of the meatus further distally. Then uh, you will approximate the lateral edges of the glands together and bring it behind the meatus. So this is what we do in a simple MAGPI procedure. So there is a pseudo advancement of the meatus. You are actually bringing the glands tissue behind the abnormal meatus, and in a way you are so there is pseudo advancement of the abnormal meatus by after the glands mobilization. Then there is something called as a Arab modification of the MAGPI procedure. In this procedure, actually what we do is, it is similar to MAGPI, but only thing is that instead of simply mobilizing the glands tissue, we will be raising the gland swings properly laterally, and then mobilize the glands posterior to the neomeatus. That is Arab modification of MAGPI. Now coming to tip repair, before that, Thiersch and Duplay mentioned regarding a urethral plate primary tubular recession. So that type of procedures were used when you have a wide urethral plate more than 10 mm, and they mobilize the urethral plate with a U-shaped incision and then try to tubularize it over a stent. So that was primary tubularization, which is popularized by Thiersch and Duplay. But they found that in cases of narrow urethral plate, such a tubularization will bring on tension to the anastomosis, and they were scared that it will give away and it will cause urethroperitoneous fistula. So Snodgrass modified this approach by giving a releasing incision on the dorsal, on the ventral aspect of the urethral plate, and he made a deep incision so that the incision went in and exposed the corpora. So after placing the deep incision, it will be acting as a releasing incision, and then you will be able to tubularize the available urethral plate. So that was called as tubularized incised plate urethroplasty, which is popularized by Warren Snodgrass. So tip repair, if you consider, it is actually a versatile procedure for many different anatomic presentations as compared to MAGPI, and for including proximal and the previously failed cases. So this is in brief the Snodgrass tip repair. Initially, you will be placing a U-shaped incision around a wide incision around the urethral plate. After that, you will be deglowing the penis, correct whatever codi is there, and then you incise the urethral plate in through a vertical incision, and then we can tubularize the urethral plate. And this tubularized urethroplasty which is done, it is again reinforced by multiple layers, for which you can use the adjacent tissue also, followed by skin closure. And if the urethral plate is not that wide, and if you are suspecting that tension will be there, then an inlay graft can also be placed after incising the urethral place. That is called as a Snodgrass technique. So that is tip repair along with the dorsal inlay graft, for which you can use the tunica vaginalis graft. As shown in the figure, after incising the urethral plate, you will be patching the area with an inlay graft, and you will be suturing the graft to the medial edges of the urethral plate, and then after that you will be tubularizing it, followed by a multi-layer coverage and skin approximation. Coming to gap repair, is called glans approximation procedure. It is ideal for glandular and coronal hypospadias with large meatus, especially a fish mouth meatus, and the patients having a deep glans groove. And it is almost similar to Thiersch-Duplay tubularization. Here, as you can see in the picture, we mark a horseshoe-shaped incision around the fish mouth meatus, and then excise the part of the glans tissue there. Then you will be tubularizing the abnormal meatus over a stent or an IFT in 2 layers, followed by subcutaneous approximation of the glans, and then outermost approximation of the glans. So this is called glans approximation procedure, which is feasible for glandular and coronal, some of the coronal hypospadias with a large meatus. Coming to Mathieu repair, or commonly known as a flip-flap repair. So this is a perimeatal based flap technique, which is based on the blood supply of the meatus. So it is ideally used for coronal and subcoronal hypospadias, and it requires ample penile ventral skin, which is mobile, and the meatus also should be mobile. And there should be ample ventral skin proximal to the hypospadial meatus, and the length to breadth ratio of the flap should be 2:1. Otherwise, the flap will fail because of ischemia. So, as shown in the picture, you mark the distance of the meatus from the like desired site for a neomeatus, and then you take the same length behind the abnormal meatus, but making sure of the fact that you take a 2:1, the length is to breadth ratio of 2:1 for the flap, and then once you incise the flap, or once you raise the flap, you flip it over towards the glans region, so that you will be creating an tunnel distal to the abnormal meatus, so that you are bringing the neomeatus to the glans region. After that, you will be doing, after glans wings raising, you will be reinforcing the repair with glansplasty and meatoplasty, followed by skin approximation. So this is Matthew's technique. Coming to pyramid procedure, this is ideal for a megameatus intact prepuce. We know that in case of a megameatic intact prepuce, there will not be any ventral deficiency of preputial skin. So, and the basic principle of this procedure is that it exposes and excises the excess tissue which is forming the urethra and reconstitutes a neomeatus and brings it to the tip. So this is the pyramid procedure. You will be placing a U-shaped incision around the large meatus, followed by glans dissection, and then you will be removing a wedge of tissue from the proximal aspect of the meatus so that you can reduce the caliber, and then do a urethroplasty, followed by a two-layer urethroplasty, and then followed by the subcutaneous closure and then skin approximation. So that is pyramid procedure, which is suited for megameatus intact prepuce cases where you cannot use MAGPI procedure or a Mathieu procedure. Coming to urethral advancement glanuloplasty and preputioplasty. So this is one of the urethral advancement techniques called as URAGPI. This is based on basically the amenability of the urethra to mobilization and advancement to the tip of the glans. Here the important thing is that the preputial skin is retained, so that in case if you have some complications, you can always use that preputial skin in later period for further repair. And complications of this procedure includes urethroplasty fistula and also urethral retraction. So this is how we do urethral advancement techniques. You place a elliptical incision over the, first you place a elliptical incision at the preputial region, followed by a vertical extension of the incision into the glans. Then you dissect the dissect in the periurethral plane and mobilize the urethra. After that, after incising the glans, the tubularized urethra is brought distally, and then around the urethra, the glans tissue is closed in two layers, and then the preputial skin is attached to the glans, so that the preputial skin is intact, and we are not excising the preputial skin. So it can be used for further repairs in the future if it will require. Now coming to preputial island pedicle flap. This was popularized by Duckett and Asopa simultaneously. It was called as preputial onlay urethroplasty, and here we use an onlay flap of the inner preputial onlay flap is used, which is sutured to the urethral plate. It can be done in two ways. One, either you can rotate it around the body of the penis as an onlay flap, or else you can tubularize the preputial flap and then do a urethroplasty or an 8 or a 10 French catheter. And this is how you do a preputial island pedicle flap. After placing a U-shaped wide incision around the abdominal meatus and the urethral plate, you will deglue the penis and then harvest an inner preputial flap, and then you rotate the flap around the body of the penis and bring it to the ventral aspect, and then suture it to the edge of the urethral plate and then cover the defect. So this is island flap, and in a similar fashion, after raising the inner preputial flap, you can tubularize the same or an IFT, and then do a like a cable grafting. You can do a urethroplasty. And only thing which we need to keep in mind when you are doing this procedure is that the suture line should come over the corpora rather than on the ventral aspect, so that fistula chances will be less. And this repair you will have to like cover with or supplement with a vascularized pedicle, so that vascularity will be more, which can be always like supplemented by the flap, followed by skin approximation. The complications, if you consider, usually the onlay technique is associated with a lower incidence of proximal anastomotic stricture as compared to the tubular neourethra. So onlay is better than when compared to tubular neourethra in this aspect, and it also provides a supporting vascular tissue to the cover the neourethra. Now coming to the post-op care of hypospadias patients, two things we need to consider. One, whether to use an indwelling catheter or not. Second thing will be the dressing. So indwelling catheter, some surgeons they don't prefer an indwelling catheter, especially for a distal penile hypospadias repair for glandular or coronal hypospadias, especially when they are doing a MAGPI repair. Some surgeons don't prefer a catheter, and some of them prefer to keep it for 3 to 4 days and then they will remove the catheter. For some more proximal cases like anterior penile hypospadias, we like to keep the catheter for minimum 7 to 10 days. And recent studies have not actually proven the benefit of a urethral catheter. The basic idea behind keeping a indwelling catheter is that you will keep the area dry, the tissue edema will be less, and it will not be disturbed by urine, so that there will be less chance for a postoperative failure. So catheter may not be used in a straightforward distal hypospadias repair, especially MAGPI repair or a Mathieu flap. Then after after placing the catheter, the child can be managed with a double diaper technique, so that the urine will go into the outer diaper and the child can pass comfortably the stool into the inner diaper without hampering each. And when you consider dressing for a hypospadias, different techniques are available, like sandwich dressing, then soft absorbable dressings are also available, but the basic system is that it should be non-adherent, absorbent, and compressive, and soft and elastic enough to accommodate any postoperative swelling. And another important thing which we should keep in mind, even if there is catheter or not, the meatus should be kept moist. We can advise them petroleum jelly based materials, or we can simply give a paraffin, liquid paraffin, so that meatal stenosis can be prevented. These are the various catheters and stents which we use. Zoan's stent can be used, that is a urethral stenting with a trumpet at the distalmost end. And on the second picture, we can just see an IFT, which is the simplest way to stent the urethra, which we use here. And some people also use Foley's catheter, but risk is that distally there will be bulb. So while removing, you should be very careful that the bulb is deflated completely. Otherwise, when you are removing the catheter, it might damage the entire repair. And also these are also urethral stents which are available. Coming to the dressings, as I said, there can be sandwich dressing or flower dressing, but basic dictum is that it should be soft absorbable dressing, so that it prevents hematoma formation and absorbs edema, tissue fluid which comes out. And oxide dressings are also used, which are transparent, and it helps in assessing the wound also. This is a gel form based dressing which absorbs tissue fluid which comes out of the repair site. It is a cylindrical dressing which is easy to remove also, which the non-adhesive type of dressing which is easy to remove in the postoperative period. Coming to the complications, the major complications associated with the surgery includes bleeding in the immediate postoperative period, but usually like intraoperative hemostasis followed by a tight dressing will prevent a postoperative bleed. If at all bleed is there, you don't have to panic. You remove the dressing and then again give a compression dressing, with which mostly the bleeding will subside. And if at all like it is progressive or if hematoma is there, you take the child under anesthesia, evacuate the hematoma, and try to control the bleeding point. Another complication which commonly happens is which can happen is a meatal stenosis. This happens mainly when we don't we do a proper meatoplasty with spatulation. As circumferential meatus has got high chance for going into meatal stenosis, and also in postoperative period also it is needed that we need to keep the meatus wet with a paraffin based dressing or a local application of liquid paraffin. Then another complication which can occur in a hypospadias repair is a urethral cutaneous fistula. This happens when there is hematoma formation or a improper repair done without proper supporting tissue during urethroplasty. Then coming to infections, any postoperative infection should be treated vigorously with IV antibiotics and daily dressing. Otherwise, it can give away the entire repair. Sometimes urethral diverticular formation is also seen. Minor diverticula with the normal stream can be managed conservatively without any surgical intervention. But if stream is played and if it is affecting the normal activity of the child, then we'll have to plan for excision of the diverticula and again closure of the defect. Another complication which can occur is a stricture. Mostly it will be distal stricture, which will be amenable to urethral calibration and dilatation. If it is not, like if it is a more proximal stricture, long gap stricture, then we will have to go ahead with a urethrotomy and stricture repair. Always, if the complications are recurring, then you should consider regarding presence of the unhealthy tissue of the primary repair site. And if it is not improving with multiple repairs, then you will have to plan for an complete redo repair for the same, rather than again going with the repair of the unhealthy tissue. So basic dictum in case of recurrent failures will be to remove the or to debride the unhealthy tissue and do a new repair from scratch with a more vascularized pedicle, like buccal mucosal graft can be used. Otherwise, the child will end up as a hypospadias crippled. Thank you.
So, Setu, it was a good presentation.
Yes, sir.
So I don't think other thing is we should not be using words like hypospadias cripple and all those things.
Yes, sir.
And that's one thing.
Yes,
Second is you regarding that the cardiac correction, no?
Yes, sir.
So what is fairy cuts? What do you mean by fairy cuts, and how different it is from the grafting?
Corporal. Sir, multiple corporal uh, cuts, incisions are placed, sir.
No, one is you told urethral plate division.
Yes, sir.
Second is the grafting.
Yes, sir.
So how different it is from the grafting to the fairy cuts? So have you
Yes.
seen that?
No, sir, I have not seen.
Okay. Now in the fairy cuts, what they do? Who has described this, and what he does it?
Snodgrass described the fairy cuts.
Okay. So how deep the fairy cuts will go?
Sir, it should go from 4 o'clock to 8 o'clock, sir.
No, that's okay. But that is from say 9 o'clock to 3 o'clock.
3 o'clock.
You make small cuts.
Yes,
Okay.
sir. Yes, sir.
But the cut will not go into the albuginea. It will not
Okay.
cut and expose the cavernosyl tissue.
Yes, sir.
So then fairy cuts will be just short of the albuginea. Just superficial part of the albuginea may be cut. Preferably only bucks fascia.
Understood.
So entire 2 layers of bucks fascia will be cut and multiple levels.
Yes, sir.
3 to 4 cuts will be given.
Yes, sir.
So, but in the graft, you cut into the tunic albuginea and expose the
Corpora.
tissue corpora.
Yes, sir.
So that requires grafting.
Yes, sir.
Okay.
Understood.
So other one is in the Arab procedure, no? In the Arab
Yes.
procedure, so it is not mobilizing the glans wings. The stitch configuration is different. So in a straightforward MAGPI, you take a midline stitch. You take a midline stitch proximal to the meatal the skin and pull it upwards.
Yes,
In
sir.
Arab, you take always paramedian. That means it will become almost like a M. So
Understood.
instead of midline one stitch, you take a 2 stitches paramedian and lift the glans up, so that the meatus will be down only. So the glans part will go up, and then you close the 2 layers. So I think
Yes.
if you go into the pictures, you'll understand that.
Yes, sir.
So it's not like only mobilizing the wings. It
Okay.
is even stitch configuration also is different.
Different.
And as for the catheter is concerned, now some of the centers are most distal hypospadias, like you told, like anterior penile hypospadias and subcoronal, coronal, and glandular. Some people say no catheter is required. I think that is a debate. Means every surgeon has a different way of managing it. So I think that is open for discussion.
Yes, sir.
Sir, Ram sir. So your opinion and the input, sir.
No, I'll just make some funny remarks. Just that Duckett was such a giant fellow in the field of pediatric urology. He was called as the Pope of Philadelphia in pediatric urology.
Okay.
So whatever Duckett said had to be accepted by everyone. So on the sidelines, they used to make fun of MAGPI because MAGPI always used to fail, invariably. It was not 100%. It used to fail 125 to 150%. So if MAGPI fails, you needed to do some really major procedure to correct the penis. So the patients used to curse. So the surgeons who used to repair MAGPI later, after Duckett had done it, they used to call it as magnificent phallus illusion. That was the name they gave for MAGPI.
So what was that?
He was
Surgeons did?
what is that?
So they did redo MAGPI or so what said again?
No. They had to do something really, really drastic.
Oh, okay, sir.
Like some sort of a stage procedure or something they had to do after the
Okay, sir,
mess
okay.
which was left after doing MAGPI. So
Right,
it used to give horrendous results. So that's why it was called as magnificent phallus illusion. That's what it was called. And also, it is nice to have young people like Setu to present because there is a complete confident tone when you're presenting.
Absolutely.
Whereas people like us, when we are presenting, there will be a lot of guilt when we are talking. Ayo, we'll be thinking when we are talking. Ayo, ನಂದೀಕೆ ಈ ತರ ಆಯ್ತಲ್ಲಪ್ಪ, ನಂದೀಕೆ ಈ ತರ ಆಯ್ತಲ್ಲಪ್ಪ. ಆದ್ರೂ ನಾನು ಪ್ರೆಸೆಂಟ್ ಮಾಡ್ಬೇಕಲ್ಲಪ್ಪ hypospadias ವಿಷಯ ಅಂತ, like that. So only the evangelists and the neophytes can confidently talk about hypospadias. The evangelists are the people like hypospadias and Duckett. I mean, Snodgrass and Duckett. So Snodgrass is so confident when he talks that Rama Jayanti and other people will be sniggering at the sidelines, saying that always he'll be talking of data, and he will not be producing any data at all. So there are lots of critics for Snodgrass also.
Yes.
So I think Snodgrass brought in a paper which showed that the complications of tip repair increased after using pre-op testosterone. That was one of his papers.
Yes, sir.
So you can just check that paper and see.
Sure.
I don't know whether it was Snodgrass or somebody working with him. Okay.
Yes,
So
sir.
anyway, this field is rife with a lot of controversies and all that. So one of the nice books which you can probably try to hack and download is Haddad's book on hypospadias. Very beautifully illustrated, very nicely explained. And he's supposed to be an excellent surgeon, Egyptian surgeon. Haddad, Mandar Haddad is the
Haddad,
name.
sir.
Haddad.
Okay. Yes, sir.
Haddad. Haddad. Haddad.
Yes, sir.
Okay.
AD. Sir,
Hadidiya.
it is Hadidi or
Okay. Hadidi, I think. Hadidi.
Hadidi,
Okay.
sir. On Egyptian we have.
Egyptian.
No, he's in Germany. No, is it?
Germany. Okay.
Yeah. Just download his book. It's very nice.
No, I think
Beautiful,
all these people have their the soft copy, sir.
Okay, it's a beautifully illustrated book. It is a very nice book. I was confusing whether it was Haddad or Hadidi. I think there's a Haddad also. Another surgeon is there. Haddad also. Both of them are Egyptians. I don't have anything to add because I just wanted to lighten the mood. That's all.
Absolutely, sir.
Yes, sir. Gauri sir is also online, sir.
Yeah. Gauri.
No, Babu. It was a good presentation.
Yes.
The last run to the research said
What? You if you are in the business for a long time, we don't speak more.
Yes.
So just wanted to know, regarding the coded test, is there any other way other than different techniques for
Sir, no. Other ways.
Is there any major
Gauri, your voice
Sir.
is not very audible, Gauri.
Hello, sir.
there is some it's okay. Probably the next
Hello, sir. I think someone.
Your voice
You.
here. So close. We can listen.
Uh, hello.
Setu,
Yes, sir.
hello.
Yes, sir.
Is there any other prescribed for achieving outside direction if other than decreased maneuver?
For sir, for Cody correction, sir.
No, no, no.
It's
For testing the cardi.
yes.
Yes. You don't want to inject the saline. There are some this things, any other technique.
Mm,
Additional this one. You think and find it out. Yeah. There's
sir,
some other technique.
don't know, sir.
They have been described.
Yes, sir. I'll find it out.
Yeah. Just additional from that.
Yes,
That's perfect.
sir. Sir, meeting will end in next 5 minutes, sir.
I think we okay. So we can finish the meeting.
Okay, sir. Okay. We'll end the meeting, sir. Then.
Yeah, sure, sure, sure.
Sir, thank you, sir.
Thank you, thank you, sir.
Thank you, sir.
Thank you, sir. Thank
Thank
Gauri.
you, sir. Thank you, sir.